Critical thinking and coding tips for Chapter 14. Okay, our first critical thinking question for this chapter. Are Alzheimer's disease and Alzheimer's dementia coded the same? And our answer to this question is no. Alzheimer's disease is coded as 331.0 only. If accompanied by a specific kind of dementia, such as senile dementia with Alzheimer's disease, code both the type of dementia and Alzheimer's disease. In the example, 290.0 and 331.0 would both be coded. If the documentation states Alzheimer dementia, code two codes, which is one to classify the Alzheimer's disease, 331.0, and an additional code to describe dementia in diseases classified elsewhere, 294.1x. Next question. What is central pain syndrome and how is it coded? And our answer, central pain syndrome is a neurological condition caused by injury or problems with the central nervous system. The etiologies of central pain syndrome may include stroke, tumors, epilepsy, brain and or spinal cord trauma, multiple sclerosis, and Parkinson's disease. Pain is usually constant, moderate to severe in intensity, and worsened by touch, movement, emotions, and temperature changes. Now, sensations might feel like pins and needles, or pressing, aching pain, or brief excruciating bursts of pain. It's coded as 338.0 and might also be documented as Dejerine-Roussel syndrome or myelopathic pain syndrome, or thalamic pain syndrome. And our final question, how are seizures that are a late effect of a stroke coded? And our answer, because the seizures are a late effect of the stroke, use the code from category 438.XX. In the case of seizure, use 438.89, other late effect of cerebral vascular disease. Also, code 780.39 to classify the specific residual condition of seizures, because there is no combination code for this condition. If this is the reason for admission, the late effect code 438.XX can be used as the principal diagnosis. Next, we'll go through a few coding tips for this chapter. Now, coding residuals of strokes. If a patient comes to the hospital with a stroke and all symptoms and or residuals clear before discharge, only code the stroke and no residuals. However, if residuals are present at discharge, code them as current because the residual condition will require continuing care. If a patient is admitted because of a late effect of a previous stroke, sequence the late effect code as the principal diagnosis, and, if necessary, an additional code to describe the residual condition, such as a seizure. Next, multiple sclerosis. Multiple sclerosis is suspected of being an autoimmune disorder in which antibodies attack and destroy normal myelin tissue. Demyelinization occurs and prevents the proper conduction of nerve impulses in the body. This can cause muscle weakness, numbness, and paralysis. It's a chronic condition marked by periods of remission, meaning no symptoms, and relapses, meaning exacerbation of symptoms. There are treatments that can shorten the exacerbations, but no cure for the disease is known. When a patient is in remission, the patient still has the disease but is not currently experiencing signs or symptoms in the case of multiple sclerosis. There is only one code to describe current MS, MS in remission, an exacerbation of MS, and that code is 340. Next, we'll discuss the different forms of epilepsy. First is grand mal epilepsy, which is characterized by loss of consciousness with convulsive seizures that can include tonic, meaning stiffening and contractions of the muscles, and clonic, meaning jerking of the extremities. Next is petit mal epilepsy, which is characterized by momentary loss of awareness but no loss of consciousness or convulsive seizures. Next is focal epilepsy, which is described as one part of the body jerking and twitching but no impairment of consciousness. And then the last, temporal lobe epilepsy, where there is an abnormal brain activity with impairment of consciousness. Okay, intractable epilepsy means that the epilepsy is difficult to control by conventional treatments and can be any type of epilepsy listed above. Next, lumbar punctures. A lumbar puncture can be done diagnostically. During this procedure, cerebral spinal fluid, or CSF, is withdrawn for laboratory analysis via a needle inserted between two lower lumbar vertebrae. CSF is normally a clear liquid. The analysis might include a culture, cytologic examination, and cell counts to determine if there are abnormalities present, such as bacteria or cancer. It can be done to confirm a diagnosis of meningitis. It can also be performed therapeutically to drain excess CSF fluid. Next, coding probable epilepsy. Typically, the coding guidelines state that any condition stated as probable, possible, suspected, questionable, or rule out would be coded as if the condition were established. However, this is not the case with epilepsy. The coder should query the physician to clarify before assigning the code for epilepsy. As with AIDS and cancer, the diagnosis of epilepsy can have social and work-related consequences that might affect the patient. Now, coding of blindness. Physicians will often document blindness in vague terms. However, ICD-9-CM provides detailed codes to describe specific visual impairment in the future. When MSDRGs are determined by severity of illness, the more detailed the codes are, the higher the MSDRG may become. It's a good habit to begin coding as specifically as possible for coding principal diagnoses as well as secondary diagnoses. And finally, a shunt that is used for treatment of hydrocephalus to drain the excess fluid from the brain. A shunt has three major components. The first is the hollow tube with holes that is inserted through the skull and into the ventricular system, where it's connected to the second component. The second component is a pressure valve that regulates the amount of cerebrospinal fluid that is released. The last component is a distal catheter, which is a long tube that attaches to the valve. It's placed under the skin in a distal body cavity, such as the peritoneal or pleural cavity. Now, if any of these components are replaced, a V code would be used as principal diagnosis to show the fitting or adjustment of the shunt, which is V5301. However, if there is any complication of the shunt, use a complication code 996.XX through 997.XX.